So the topic of my article is Madurai CVTS, that is cardiovascular and thoracic surgery ICD removal scoring system. So systematic and a scientific scoring system for helping in intercostal drainage tube removal. So this is my department. So first introduction about an intercostal drainage tube. It is done in, from my experience with ICDs, we are doing at least 10 to 15 ICD insertions per day in my duties. So intercostal drainage tube is done as an emergency and also an elective procedure. And of course, it is a life-saving procedure in some conditions like tension pneumothorax and a massive hemothorax. And also, this ICD insertion is done as a standard post-operative practice after a cardiac surgery. It may be a pleural or a mediastinal site for draining the blood fluid to prevent the tamponade effect or the air leak. So, what are the other conditions where we insert ICD are? We can insert ICD for a pneumothorax or hemothorax following a trauma, or maybe due to a pneumothorax that occurred because of rupture of bullae in a bullous lung disease, leading to a spontaneous pneumothorax which needs an ICD insertion. And also in conditions like malignancy, that may be a secondaries in a thoracic cavity or even a primary lung malignancy, that may be a malignant pleural effusion which requires an ICD insertion. And in conditions like decompensated chronic liver disease and chronic kidney disease, in cardiac failure, patient will have a volume overload status. And because of this volume overload status, there can be accumulation of fluid in the third space and this is resulting in a pleural effusion, which is also supposed to be removed by ICD insertion so that lung can expand well. And in conditions like pulmonary tuberculosis and any other infections, there can be a reactionary effusion which needs an ICD for draining the effusion. And in case of destroyed lung because of any pulmonary infection, there can be a spontaneous pneumothorax. This is also requires an ICD insertion. So this slide shows the etiologies for ICD insertion. So coming to the drainage system, either we can go for a continuous suction drainage system or an underwater seal drainage system based on gravity. So what are the disadvantages of ICD draining system? Patient can be mobile with ICD tube itself, but most of the patients are not getting mobilized because of the pain because of ICD. And the assessment of the air leak and the assessment of the X-ray features are having a very high inter-observer variation is there. So it may be a massive air leak for one person and it may be a moderate air leak for another person. So because of this high inter-observer variation, we are supposed to have a specific standard protocol for removing the ICD. So there are many studies dealing with the different drainage systems like a digital drainage system following a thoracic surgery or a manual drainage system, but there is very little data being published for an application of a protocol based ICD drainage system removal. So this study is a prospective randomized controlled trial designed to study the efficacy of the ICD removal scoring system. So here we designed the ICD scoring system and also checking the efficacy of this scoring system. So the aim of the study is to devise a scientific and a systematic method to assist in the ICD removal, decision making of ICD removal. So here the main aim is that the decision should be reproducible with application of the scoring system. And also the study is aimed at checking or studying the efficacy of this ICD scoring system in different etiologies. So here around 1,000 patients admitted in government Rajaji Hospital Madurai were included in this study, and this study is a prospective observational study, and the study is done in government Rajaji Hospital Madurai, India, and the study duration is 24 plus 1 month of pilot study. So here the inclusion criteria for the study is all age group people were included in the study, both male and female were included in the study, and here the people are grouped based on the etiology for which the ICD is being inserted. Of course, the post-cardiac surgery patients are also included in the study, and patients who required ICD insertion for a pneumothorax or hemothorax with the traumatic etiology were also included, and other chronic conditions leading to conditions where the pleural effusion can occur, which needs an ICD, are also included here. The exclusion criteria for this study is patients who are not willing to get enrolled were excluded from the study. So coming to the parameters assessed, here in the study we assess the incidence of ICD tube reinsertion after the removal of the tube and retention time for thoracic drain, that is ICD tube, and the physical characters like the volume of the drained fluid, color of the fluid, and the site of insertion of ICD, maybe a mediastinal or pleural, and the presence or absence of air leak is being assessed. And also the radiological features based on the chest X-ray findings are assessed here. And the incidence of rethoracotomy due to tamponade or bleeding after removal of ICD was assessed here. And the length of the hospital stay are assessed. So these are the parameters which are assessed in this study. So study procedure. Initially, after getting the patient enrolled in the study, patients are categorized into different groups based on the etiology. I'll show the groups here. So there are group A to E. Group A included patients around 554 patients who needed ICD insertion for dramatic etiology. And group B included 137 patients who needed ICD insertion. The primary cause is malignancy, maybe a CA lung, primary lung malignancy, or a secondary in thoracic cavity. And group C included 126 patients who needed ICD insertion for systemic illness like decompensated chronic liver disease or a chronic kidney disease. And group D included 107 patients where the ICD is inserted for conditions resulting because of a pulmonary infection. And group E included 76 patients where the ICD is inserted for rupture of bulla in a bullous lung disease. So in the study, the patients are grouped into different categories based on the etiology, and in each categories, the scoring system was applied to decide when the ICD to be removed. So patient was followed up for 7 days after removing the ICD for looking for complications, preferably recurrence of the cause for which the ICD is being inserted. So this is the scoring system here. Here we have two parameters here broadly, maybe a physical character of the drain and the radiological features. In physical character of drain, it is a volume, color, site, and air leak was included. In volume, if the volume of drain is more than 200 ml for last 24 hours, it is considered to be a 0 score. And if the volume is between 100 to 200, the score is given as 1. And 50 to 100 ml for last 24 hours, score is given as 2. If less than 50, the score is given as 3. And in case of color of the draining fluid, if the drain is bloody, the score is 0. And if the drain is purulent, the score is 0, which means that we are not supposed to remove the ICD in these two conditions. And if the drain color is serosanguinous, it is given as 1. And if the drain color is serous, it is given as 2 points to score. And the site of ICD insertion is pleural 1 and mediastinal 2. Because pleural ICD has a dependent drainage, so this can be left for a longer time than the mediastinal drainage. And coming to air leak, if air leak is present, it is 0, and if air leak is absent, it is 1. Here, the higher the scoring system, more likely to remove the tube. Coming to the radiological features in X-ray chest, if there is an inadequate lung expansion in X-ray, it is considered to be a 0 score. And if there is a blunting of costophrenic angle, otherwise adequate lung expansion is present, it is 1. And if adequate lung expansion is present, it is 2. So this is with the ICD scoring system for adults. So higher the score, ICD can be removed here. So if, for example, if a patient has a drain of less than 50 ml for last 24 hours, the score for volume is 3. If the patient has a serous drainage, it will be 2. So 3 plus 2 is 5. And the site of ICD, if it is a mediastinal, it will be 2. So it will be 7. If air leak is absent, the score is given as 1. Likewise, when the score is high, the ICD tube can be removed here. So 8 to 10, if the score is 8 to 10, ICD tube can be removed. And if it is 5 to 7, ICD can be clamped for less than 3 hours. And you should watch for clinical signs of respiratory distress. If no distress is there, then ICD can be planned for removal. If not, you have to continue the ICD if patient gets respiratory distress. And if the score is less than 5, when the ICD is non-functioning, then we are supposed to go for ICD repositioning. If ICD score, removal score is less than 5, with ICD functioning well, then we have to continue ICD. So this is for adults. In case of pediatric age group, that is less than 12 years, we are just changing the volume alone. In physical characteristic, the volume is alone being changed. If it is less than 10 ml, the score is given as 3, and 10 to 20 ml score is given as 2, and 20 to 50 ml it is 1, and if more than 50 ml drain is there, it is considered to be a 0 score. Whereas other parameters like color, sight, air leak, and the chest X-ray findings are same here. And the scoring for system is also same. Only the volume changes here with the pediatric age group. So findings of the study, in group A, where traumatic etiology was there, number of candidates present were around 554. Here there is no incidence of any reinsertion of ICD required in less than 7 days or even up to 14 days. Patient does not require any reinsertion of ICD. In group B, where malignancy is the etiology, around 137 patients were included in the study, of which 5 people required around reinsertion of ICD within 7 days, and 19% required reinsertion of ICD within 14 days. In group C, where the systemic illness like DCLD or a CKD, that is decompensated chronic liver disease or a kidney failure, contributes to the cause for ICD insertion, 126 patients were involved. Of this 126, 0% of people required ICD reinsertion after removal by applying the scoring system. While these patients are followed for next 7 days, around 10% of people required reinsertion of ICD. In group D, where pulmonary infection is the cause for ICD insertion, 107 patients were included in the study, of which no patient required ICD reinsertion when ICD is removed after applying the scoring system within 7 days. But after 7 to 14 days, around 7 people required reinsertion of ICD. In group E, where pneumothorax because of a rupture of bulla occurred, around 76 patients were enrolled in the study. Of the 76, 5 required ICD reinsertion within 7 days, and 4 people required ICD reinsertion of around 7 to 14 days. So totally 9 out of 76 patients required ICD reinsertion here. So observation of the study, there is no gender predisposition noted to influence the ICD removal, and also age factor has no influence on the ICD removal here. So in our study, the gender distribution is 76% of patients are included in the study were male, and 24% are female here. And age distribution, only 4% of the people, or 4% of people were male children, that is less than 12 years. And majority are adult males, around 758 numbers, and in adult females around 238. So ICD reinsertion in percentage, in group A, only the group B and group E had a ICD reinsertion within 7 days. Group B is because of malignancy, and group E there is a bullous lung disease, maybe associated lung disease was there. So that etiology can be attributed for the reinsertion of ICD. Whereas in group B and E, it is only just 5%. So this is the incidence of ICD reinsertion within 15 days. First slide was patient was followed for first 7 days, and this slide shows the ICD reinsertion incidence for first 14 days. Here the incidence is 14% in group B, and it's 8% in group C, and 7% in group D and E. So coming to the statistical analysis, here the values are expressed in average, and the association between the categorical variables and outcome was tested by using a chi-square test, and the diagnostic accuracy of the scoring system was evaluated using the ROC analysis, that is receiver operating characteristic analysis. So the study population of the 1,000 people involved who underwent ICD insertion, the mean age of participants in the study are 35 plus or minus 5. And the sample consisted around 76% of male and 24 is female. So there is no statistical significance associated between the age or gender and ICD removal, because the p-value is more than 0.05. So next, the Of the 10,000 population, by 7th day, only 1% of the study population required ICD reinsertion, which means only 10 of the 1,000 people who was included in the study required ICD reinsertion after removing the ICD by applying this scoring system. On 14th day, when it was around only 5% of the study population required ICD reinsertion, and this is a very significant value. By using a man-Whitney U-test, this is a very significant value showing that ICD reinsertion was significantly reduced when this scoring system is applied and removed. So diagnostic accuracy of this scoring system is studied using the receiver operating characteristic, that is ROC analysis. Here, by applying this ROC, we find that the optimal cutoff score for safe removal of ICD is more than 8. So, the result of our study, the incidence of ICD reinsertion is present in few groups. Of course, it is present in the 1% in 7 days and in the 5% in 14 days. And this is attributed to the etiology for which the ICD is being inserted and natural course of the disease. Like a patient with malignancy, they can get a repeated effusion. And also patient with a systemic illness like a DCLD, chronic liver disease or a chronic kidney disease, they are also getting a repeated collection of fluid for which they may require an ICD insertion. And bullous lung disease also, if not treated, for the primary cause. And this scoring system is found to be effective in determining whether you have to remove the ICD tube or to continue the ICD tube. And the incidence of reinsertion is not that significant when removed after applying this scoring system. So, conclusion of the study. So, this ICD removal scoring system is a scientific and a systematic method to aid in the ICD removal, and this helps in preventing the ICD reinsertion because of yearly removal, and this also eliminates the inter-observer variation, and this also provides an effective method for ICD removal in different etiologies. And also the scoring system as an evidence-based scoring system, and this is a reproducible one. The shortcome of the study is that number of pediatric population included in the study is very less. So maybe the second part of the study we can go with the pediatric population. Sir. Thank you, sir.
Thank you very much. Very clear. I believe nobody will contest the benefit of this scoring system, especially for young fellows.
Yes, sir.
Is at the beginning is better, to put very strict rules and make them respect them. You decrease the rate of complications. I believe it's very. Do you have some questions? No. Yes. Yes. How Natalie is asking how to get access to the scoring system is on internet.
How to? Sir,
to get access to.
It's open for all, sir.
Open
for all.
Did you publish this one? I encourage you to publish in the Journal of Humanitarian.
This is the first forum I'm presenting the scoring system, sir.
First time you present?
Yes, sir.
Okay, I strongly encourage you to make an article.
Yes, sir.
And send, to the Journal of Humanitarian Cardiovascular Medicine.
Yes.
If you need also some help, I will help you to write the article in order to respect, some rules and methodology.
Sure,
okay,
sir.
thank you very much.
Thank you, sir.